as Danielle said, I'm Albert Chan, and I'm just really here to share my story of how we came to Sutter Health. And in fact, I'm often fond of saying I was born to work at Sutter Health because, in fact, I was born at Sutter Health back in the day. Maybe as a brief introduction, a little bit about Sutter Health and a little bit about why I came into this work. Sutter Health is a 24 hospital system in Northern California. We have 14,000 clinicians, 50 plus thousand employees, taking care of over 3.3 million patients annually, to give you a sense, and a geography that spans several hundred miles. So trying to function as one system. Joy, I know the work that you're about to do is quite challenging. We did that a few years back, and I'm still at Sutter, so that's good. It's a challenge to really create one patient experience, and we really thrive on that. Back when I was an informatics fellow, this was one of my projects to help launch my chart. As I mentioned, we were the first in the country to do this. And this actually really stems from failure. So all good things come from failure, I will say. So I was an informatics fellow at Stanford and doing a project on decision support. Anyone do decision support in this room? Yeah, okay. So you all know, and I like to publish, so how many of you publish negative trials? Yeah. Some good scholars in the room, thank you very much. But that's what happens. I'm an early informatics fellow, and I said, gosh, we had this great system across 3 systems, the Boston VA, Duke, and Stanford. And we had some great outcomes, but the primary endpoint was a negative trial. And so I thought to myself, I spent all this time, and my colleagues spent all this time doing this work. It still persists. It's a great piece of work, but it highlighted one thing for me, which is it's really important to have the patients involved. Because essentially the intervention we did is doing a decision support tool for doctors. In fact, I wrote a paper about why doctors said they didn't follow the advice. That tells you, it gives you a sense of doctors. And so and I'm one too, fair enough. So that's why I really focused my career, excuse me, but focused my career on how do we involve the patients? You know, how do we get the patient involvement and having that win-win in synchrony together? And one of my first patients at Sutter was a patient who had suffered from a stroke, unfortunately. And for the providers in the room, you can imagine a patient who suffered from a stroke who got all of his motor function back, but the one thing he had left was aphasia. So he brought a white dry erase board, and we tried for 40 minutes to try to communicate by a dry erase board. Because he just, he couldn't come up with the words. He knew what he wanted to say. You could see the frustration, but he couldn't come up with the words. And so this is where this project really took off for me, to say, this is not e-care or digital health. This is about care. This is an opportunity to help this man recover. I mean, he was a former CEO, so position of power, and humbled by the fact that he couldn't speak. And it really changed my career, frankly. So I've looked for opportunities since then to really empower our patients. I spent many years as a CMIO, and then had the opportunity when Sutter welcomed me to take a system role in digital health to really focus on patients. And so let's dive into the talk a little bit. So are we in a digital age? Okay, let's full transparency. How many of you sleep next to your cell phones? Just look around for a second. When asked, 80+% of Americans sleep next to their cell phones. I didn't say sleep with, but sleep next to their cell phones. It's an incredible thing. In fact, this is some data that Mary Meeker has from Kleiner Perkins. Almost 6 hours per day. Every adult, 6 hours per day in some sort of digital media. Incredible. We spend a lot of time. We are fully addicted to these things. And it presents an interesting opportunity, I think. This is data from Epic. They were kind enough to share this slide with me. In green is data access in the EHR by doctors. In blue is data access by patients. I'll let you just look at that for a second. This is unique data from 12 different organizations who are Epic customers. Fascinating, right? So at the face of it, you think, oh, we're creating this database for doctors to access data, but in fact, it's the patients who benefit from this the most. And I always try to keep this in mind. So Another thought question. How easy is it to navigate healthcare? Not at all, right? In fact, this is what I think of for Joy, this could be your EHR implementation project. For patients, it could be just trying to get an appointment. This is what it feels like for most people. So one of the things I've dedicated myself to doing, and my team is really dedicated to doing, is trying to reduce friction. Because no matter how good the doctors are, if you can't get to see your doctor, it just doesn't work. And we just got to make it better. So one of the things I'm challenged with is often the question of how do we balance the needs of the doctors and the organization and the patients? And I think many people often say it's a trade-off. It's if you help the doctors, you hurt the patients, and vice versa. And I think that's a false dichotomy. So someone posed this question: is there an ROI to patient-centeredness? And I hope to present some examples of, in fact, that there is ROI. We mentioned earlier that we've been live on MyChart since January 1, 2001. 2001. God forbid. 2001. I'm an old person now. And we've really routinized how we enroll patients. So essentially, as every patient comes into the exam room, we look at their status, and we really try to make sure that we enroll as many people as possible. So you can see here our rates. I want to just give you some highlights here. So enrolled, we're nearly 1.7 million patients, which is about, in some markets, as high as 80+% of some of our adult patient populations, depending on region. So we have lots of engagement. And I'm going to talk about some of the positive benefits and some of the unintended consequences of what's happened with that experience. Just some other things we measure. So how many health reminders? That is to say, if you have a chronic disease, do we remind you to get your A1C checked or your cholesterol checked or things of that sort in an automatic fashion? And I'll share some data with you about how powerful that is. You can see here lab results, scheduling appointments online. In 2010, we did about 10,000. And then I said, this is ridiculous. So over the last several years, I've been really plotting a plan to make it possible for patients to book their own appointments online, which required a lot of actually standardization and collective work together to make it possible. Because it's not technology, right? Technology is make an appointment. The cultural side of these things, what I'll call socio-technical things, are figuring out what are the barriers that clinicians may face in trying to offer this service and trying to help people have a win-win. So we'll talk about that a little bit as well. And you can see here we saw a 40% increase year over year. And by the way, there's real ROI there. We estimate it saves us about $6 per transaction if the patient books it themselves. So that's pretty $5 to $6. Similarly, payments process. Joy, you mentioned about bill pay. What we've noticed is a couple of things. We used to have two separate systems for hospital billing and ambulatory or office-based billing. That was also ridiculous. And you'll hear me be a little crass. Sorry for the folks recording this. My boss is not here. The simple fact of merging the two systems, so going away from a third-party vendor and having it both be an Epic, we saw that first year a 40% increase in bill payment online. And you can understand the transactional savings as well as the patient experience benefits. So pretty strong ROI case. And as we approach total cost of care models or value-based payment models or increasing cost pressures, I think it's inherent on us to say, what are the low-hanging fruit? What are the things? Let's see. Let's try to change doctor behavior. Doctors, can you raise your hand? How easy is that? Oh, okay. Or can we just fix the things we should fix? Can we reduce friction to things that we should fix to support our doctors, to make it easier? So those are some of the targets we target today. They're not sexy, but if you're going to be a truly digitally literate organization, you have to fix those digital infrastructure things. It's sort of like patient surveys. You could have great doctors, but if your exam rooms aren't clean, people think you're a bad organization. And I think the digital front door is the same thing. I'll give you an example of some changes we've done. And by the way, one of the things I'm going to share with you is it is not about technology. It's not about buying new software. In fact, I'm embarrassed to say some of the examples I'm going to share with you are things we owned but didn't fully deploy, which may be a common theme, right, Joy? Yeah. So here's an example. So we owned the software to do text reminders to patients about things. So our simple use case was, in some of our clinics, we had 8 to 10% no-show rates. This is in the face of wait times for appointments that were quite long. So we had both situations at the same time. We had poor access because people were busy, and yet these appointments lay fallow. So we had both in the same time, and so I said, what can we do to improve that? And the challenge was, and anyone as a leader has an OS moment, and I'll leave those 2 letters unfilled. But so what happened was my boss said to me, hey, can you come up with something? By the way, you're going to be in front of the CEO Council next week, and you have to get it done within 3 months' time. I said, thanks, boss, man. But I came up with this idea. So I looked around and said, hey, we have this software we're not using. We could remind via text about appointments. And I actually looked it up. The Cochrane database, for those who are academically interested, showed 14% improvement with automated systems. And in fact, we had the system in place. So here's some data. Here's an estimated cost of automated reminders versus manual reminders. So we had the software in place to do voice and text reminders. We had a number of practices, almost 51% of our practices said, I think it's better, instead of using automation, let's have Nurse Nurse Betty, let's use a better name, manually call each of my patients to remind them. 51% of our practices believed that was the better practice. And you can see the annual cost of our back of the envelope cost approximations for doing that. Plus, it wasn't very reliable, and those nurses could be taking care of patients in other ways. I mean, that's the other obvious thing. So that's what we did. So raised an enterprise-wide approach. As I mentioned, we have a number of clinicians throughout the system, and getting them all to adopt this was interesting in 3 months' time. Here are the results. Again, to the concept of ROI for consumer-centric practices. Our no-show rates, depending on site, reduced from 9 to 19%. Because we now are able to text people about their appointments, they can easily cancel. When they cancel and let us know that they no longer can come, we can automatically, behind the scenes, offer that appointment to someone else. So that automatic wait list functionality improved access to primary care by 15 days. That's just to say, I had an appointment and I wanted to be seen sooner. I could be seen 15 days sooner in primary care and 23 plus days sooner in specialty care. All with a simple intervention. And slot utilization went up by 2%. And for the academics in the room, we published some of this in Health Affairs because we thought it's important to say, there's some important things to talk about in consumer-centric approaches to healthcare that can benefit. And we can learn from each other. So as I said, 3 months, OS moment. I didn't write that in the slide. No new software, and enterprise-wide. So one of the other things I'll focus on is scale. So I think there's this really bad disease in our industry. It's called pilotitis. It's a common disease. It's let me just pilot something because that makes it easier to get it done, with no plans to scale whatsoever. And that's just crazy. So let me give you another example of some work we've done. I mentioned about digital infrastructure, and really it's just infrastructure. So if you want to offer digital appointments, you got to fix your underlying appointment structures. You got to work with your doctors and say, what are the barriers that you're facing? And in fact, so I looked under the hood and said, in primary care, we had something like 13,000 primary care scheduling rules. 13,000. That is to say, some poor human person had to go through a book of rules, in addition to the rules that weren't written down, by the way, and go through them before you can make an appointment. So in some of our centers, it took over 6 minutes to make an appointment, and you can now figure out why, right? You had to have deep knowledge of that doctor's preferences. In fact, that doctor probably didn't even know. The thing we noticed is a number of the doctors just copy and paste. They didn't really even know some of the rules they had. It's fascinating, just fascinating. One of our doctors had a rule that said, and pardon me, but he said, I would not like 2 Chinese-speaking patients back to back. I'm using Chinese because I'm Chinese. It's actually a different language. What he was really saying is those patients were quite demanding of his need for care, and he was trying to protect himself. But you can imagine a rule like that being very difficult to navigate. So there's rules like that. So we put together what we called a standardization of scheduling initiative. And by the way, that doesn't roll off the tongue, nor is it very warm and inviting. So one of the lessons learned was we switched to a new title called patient-centered scheduling, which appealed to people a lot better. And it's true. What were the key elements? Portability across the system. So if you can go to Costco, I'm in Washington, right? So if you can go to Costco and find items across Costco, but in our system we had these clinics all over the place, but you couldn't actually schedule across. Because we had rules like for example, that said, you're a new patient, you're an existing patient in Albert's clinic, but you're a new patient in Rich's clinic. I know I can see your Epic record, in fact, but you're new to us. You'll have to wait 9 months. We had rules like that, so that's a problem, obviously. So we expanded same-day scheduling appointment capacity. The other thing we did is did a lot of like oh duh sort of things. I know you laugh, but here's an oh duh. Here's an example. So the doctor would review the lab results, and maybe one of the values is off by 1, but basically it's normal, right? Doctors know this, right? Blood tests all the time are like this. And so the doctor would document in the chart, please call the patient, tell them the results are normal. But because of HIPAA, which is great, by the way, so the medical assistant would call the patient and leave a message saying, I want to share some results with you, call me back. The patient would call back to the call center people who could see in the chart that the tests are normal. They're not making any judgment about triage or clinical knowledge, but they were stuck with saying, oh, I need to hand this off to a medical assistant or the doctor to answer your question. Back and forth, back and forth, back and forth. Doctors, this happened to you guys ever? Yeah, and now we can track this in Epic because telephone encounters help you track that. So we've working with legal, we came up with a strategy to handle that and so forth. Again, fix your infrastructure, because if you fix your infrastructure, you can actually make this work. We've reduced many of the rules down to essentially 30 core principles. 13,030 core principles now. And we got doctors from all around the system to agree, I couldn't believe it, to a common standard. Here are the results. You can see it's a little blurry, I apologize. It was a little blurry last night too, but when I was putting this together, so sorry. Patient satisfaction is super high. What I'll focus on, we have 9 key performance indicators of success. All 9 of them turn green. Things like the time to handle a call on the phone to make an appointment went down because the rules got simpler. The ability to make patient booking online got better because we made it simpler. Error rates went down. Turnaround times went down. Net experience overall. In fact, the first pilots in September went so well that 2 of our 5, if you will, counties decided to go enterprise-wide. So by December, we finished almost 90% of our practices from September as a start. Again, 3 months. I've created a new standard, which is kind of hard to beat now, unfortunately. Let's focus in on actual patient outcomes. We've talked about essentially process measures, infrastructure things. Let's talk about actually clinical outcomes. Do you need a fancy system? I love fancy systems, but let's think about stuff you've already bought. So here's an example. This is our instance implementation of my chart. There's a screen called Health Reminders. There's a similar screen on the doctor side that shows the red in the header. Those need to get the red out. So what if you wanted to screen people for hepatitis C when the new recommendations came out? So you could call people, you could do letters, you could do a bunch of things to remind them to get their screenings done. Or you could do what we did, 6 words in this screen. Hepatitis C, if you were born from 45 to 65, click here. That's essentially all we did. And but when you click here, you can actually read why hepatitis C screening is important. There's a cure that causes disease, so people can understand. And that's all we did. We literally just turned it on, put it in the system, see what happens. You can see here baseline screening of hepatitis C in blue. And you can see where we turned on the alert. Several 100,000 people received this alert automatically. Ultimately, 200 new cases of hepatitis C were discovered, and a number of people were eligible for treatment, and good things happened. 6 words. System you've already bought, 6 words. Just saying. Just saying, right? Just saying. It's a duh, my duh principle. I learned this from my kids, right? It's just duh, Dad. Here's more interesting patient-generated health data. So, so we've talked earlier about using patients as a signal, right? They text us back a response. It's a data point. Here's some more sophisticated data. What we did is in this study, give patients both access to our web portal, our patient portal, and access to devices where they can connect to us. They can send their glucometer readings directly to us. And in those teachable moments when we get the readings, we could send things back. We could send videos back. We could send them messages back, and so forth. And you can see here in dark black is the usual care, and in dotted line is the patients who received the intervention. The key thing, Pearl, for me in this study was taking advantage of the teachable moment. So leveraging that data, instead of just getting a sea of data that the doctors have to interpret, which is impossible, can you empower the patients to act and figure out what to do with this in partnership with a care manager or other clinicians? And this is what happened. So there's some pictures of our care managers. You can see our Palm Zero. Hey, this is state of the art technology at the time. So don't judge. Don't judge. That is in fact a Palm, but it worked. So unintended consequences. This is for the academics in the room, this is my favorite thing to invoke, because you can always say it in any talk you want. Unintended consequences of patient engagement. So we've actually studied this, and again, this is published in Health Affairs as well. So many years as a CMIO, implementing Epic to getting doctors to use it, this is what happened. This is a multi-year study of looking at electronic logs, so data in the EHR, to see what they're doing with their time and what they're clicking on, what time of day they're doing it. So for every 3.08 hours spent face-to-face with patients, our clinicians are spending 3.17 hours in desktop medicine. That means, and you can see on the right side of this graph, there's the red bar and the multicolored bar. These are all the different tasks that they're doing. These are all clinically related things, like refilling medications and reviewing test results and stuff before you do it, answering emails from patients, taking phone calls from patients, and writing chart notes, which is about 2 hours per day. You see patients 8 hours, 2 hours per day on writing chart notes. So you wonder why people are burned out. Again, this is my penance for trying to implement the systems, now trying to figure out solutions for this. One question Joy asked me was, what have we done in this regard to try to address these sorts of burnout questions? Probably the most crazy thing that we're doing today is, and I like to say, killing sacred cows. So we got our legal team to approve us sending video data to India, to scribes in India, in real time to take notes for about patient care. And we've seen about a 1.5 to 2 hour time savings per doctor per day doing that. And patients, at least informally via subjective surveys, have said, hey, the doctor's actually looking at me. They're not typing at the screen doing this. They're actually looking eye contact to me. Interesting, very interesting. The other interesting thing about this is building teams across the world is a very interesting phenomenon as well. We're thinking about writing this up as well. Because in the digital age, there's no reason why your teams can't be distributed. We just pushed it a little further, but it's an interesting question for you to think about as you build your digital infrastructure. Final thought question, is this really about technology alone? I hope I've showed you today that it's not just about technology. We own technology, we just didn't put it in, and there's lots of reasons why. And when you do, it actually works. So here's some data that just got published in the Harvard Business Review, an article that said digital transformation was the #1 task, or actually they framed it as risk for CEOs and other people they surveyed. And 70% of digital transformation efforts, not Joy's effort, by the way, but 70% of digital transformation efforts fail. Of the 1.3 billion spent on digital transformation, 900 million is wasted. But you guys aren't going to do that because you heard what I said. And finally, I will say this in all deference to my informatics professors at Stanford. Probably the most important course I took was a course in organizational behavior. Because I don't do Java coding anymore, or C++. But recruiting teams and leveraging good change management principles are key. This is just a picture of the team we pulled together for patient-centered scheduling, and it's worked tremendously.
So for those who don't know, this is the best picture that was ever taken of the Ochsner health system. There we go, presenter mode. This picture, they use it on the digital light switches, but it's impossible to find the original. I had to like go into tunnels underneath the hospital and everything. It was a day like today, like the only blue sky day. I think they planted all of those plants the day before. They're all kind of brown now. There's actually 6 more stories on top of that clinic tower. They always plan to expand it, but they don't have a plan to raise the elevator motors. Because they built the elevator motors on the 6th floor, and so you build the shaft in the same place, but what do? You turn the elevators off for 2 weeks in the hospital? It doesn't work. They have no idea what they're going to do. It's amazing. This is me. I have a bunch of degrees. Disclaimer, as an educated jack of many trades, I'm consulted for a lot, but responsible for little. I'm kind of like a swing-in cowboy, and I get to give my opinion on things, and I leave, and then when it's time for analysis, I come back, which is more fun than anything else. I'm going to do a brief site overview, a brief digital patient framework, case studies and food for thought, a very abbreviated grand tour of current projects, and then a small subset of when things actually work as intended and have a measurable impact on health, and then some practical considerations on building an innovation center, hopefully very quickly. So for those who don't know, this is the Ochsner Health System. Who will admit to being unfamiliar with the largest healthcare system in the great state of Louisiana? There you go. That's fine. That's fine. It's fine. We were a 2-site location in 2005 before Hurricane Katrina hit. And then they tossed a coin up into the air. If it landed heads, the only way to survive was to sell yourself. If it landed tails, the only way to survive was to buy everything. And it came up tails, and some bank said, here's $1 billion, save New Orleans and employ people. And over the 10 years immediately following, they bought 14 other healthcare systems and have been merging. Around 2011, they decided to go all in on Epic. All of these hospitals are on the same instance. This is our current map of the state of Louisiana. It cuts off things that kind of leak into Texas and Mississippi. We used to say we touched 70% of Louisiana. As of January 2019, those 2 boxes on top added in, so I expect that to come up over 90% now. The nice thing about them all being on a single Epic instance is it's all touchable, queryable. Everybody's dashboard runs off the same. It doesn't matter where you've seen, where anything has happened, none of it. We were Care Connect before there was Care Connect. The unintended consequences, you'll see that some of those are yellow. Legally, we are not allowed to do research on, this is about who owns patient data. Legally, we're not allowed to do research on any data or any patients that come out of the yellow system. But in actual testing, as soon as you've been diagnosed with anything sufficiently interesting, you're referred to the main healthcare facility, and now we can touch all of your data. So if you ask how many upper respiratory infections there are, I have to put a lot of caveats on your data query, but as soon as you ask for a cancer diagnosis and who had an upper respiratory infection, it's all fair game. Here's some stats and facts. We have the standard bimodal age distribution of people. But you have a very good payer mix, so one of the reasons we can do so much is because we see so few uninsured people. We're about 65% white, 28% African American, which underrepresents African American in the state, but for research purposes, once you get past 1 million, everything seems to work out. Residents, we got them. Part of merging with the Shreveport was we're now the largest educator of medical students and residents in the state. We have 1,500 slots now. Clinical trials, we got enough compared to somebody like Ohio. You know, it's still in a baby splash pool, but we're going to push, I think, 1,000 open trials this year. We don't open that many every year. Here's some drugs I've never heard of that we're tested at Ochsner. I don't know, this slide's like 5 years old. I don't know if anybody takes these. All right, patient engagement. That was the, I gotta save time on the front end. You can ask as many questions about Ochsner as you want. Patient engagement. Our Ochsner health system was founded by a professor, actually the chair of the surgery department, and he and 5 of his buddies decided to open a private clinic and make a hospital. And the quote that they paste everywhere on the inside of elevators, inside the lobby, is, "Don't forget that you're treating people. You're not treating disease, but people." And I think nothing gets closer to the idea of patient engagement than that. I will say, given the history of this quote, it was probably more intended to be "don't be racist." And I've also equally used this quote to talk about the importance of whole genome sequencing. But as I learned from my uncles who are all preachers, it's a very bad quote indeed that cannot inspire more than one completely different sermon. So how do you engage people? You engage people by going to talk to them. Patient engagement, we have a patient research advisory board. It's active patients who have participated in research. They're available quarterly. They're available digitally. You can give them your consent materials. You can give them your treatment plan. You can give them your analytic plan and say, does this interest you enough that you would like to participate? The number one best way to engage patients is to go talk to them. Digital engagement may not be new, but don't forget the tried and true. But that's not what we're here for, so we're just going to pretend that nobody actually wants to do it. We're here to talk about digital patient engagement. So here is my digital patient engagement : a framework. I love colons and titles. So you're a clinician or an administrator, and you're sitting at a computer, and for some reason you don't actually want to go talk to anybody. How do you engage with the patient? Well, you have to have a way to reach out to the patient. Text reminders, MyChart messages, we do all of these things. You are engaging the patient because you are making that individual patient believe that you care about them. But part of engagement is letting that patient become engaged with you. So you open up a door for things to start taking back in. You start taking in patient-reported outcomes. You start letting them change their own schedule. You start letting them put in preferences for what kind of breakfast they want the day after they give birth. But then all these people now have devices that are measuring them all the time, and you already opened a door, and you think, that's great. You know, what are we going to start? We start engaging these people. And then a much bigger arrow happens because a tidal wave is pouring through your door, and you think, this is great, but you don't really know what to do with it. So here is a grand tour of things we have done. The key takeaways of this part of the talk are, on the digital frontier, what is obvious may not work. We may not always know what work means, so we must be very honest about what we really want. So the adaptable trial. Has anyone ever heard of the adaptable trial? So Picori says digital patient engagement trials, that's the future. We're going to go to everybody who has Epic and say, you're going to run a digital trial for us where nobody has to you don't need people anymore. You need patients, but everything else is digital. So standard Epic infrastructure, by which I mean you run a clinical phenotyping algorithm to look for people who may have high blood pressure that is treated with a subset of drugs. They must have had more than 2 visits in the last year, et cetera, et cetera, et cetera. It's all very standard. You then pump out an email message or a MyChart inbox message to those patients with a custom tracking link that will take them to an online consent portal. If they click the link, they're tracked. If they consent, they're in the study. The intervention is you're randomized between 2 different doses of aspirin you were supposed to take every day. And then you have patient-reported outcomes, and that's the whole trial. Does this work? Did it work? As a parallel, you can also get phone calls. They did mail-outs. They had someone waiting in the clinic who had flagged you as an upcoming appointment of someone who they picked up on the phenotyping algorithm. They compared all of this. This is the last quarterly, so this is the end of 2018. We became the number 2 accruing site. We identified about 15,000 patients who were being seen at main campus cardiology. You can see about 12% of them will click the link. We don't know if they don't get the email. We don't know if they don't check their MyChart. As a side note, we've realized that the best time to MyChart message someone is the day before and the day after a scheduled appointment, because that's when they're double checking and that's when they're checking their results. Of those, 588 actually enroll in the trial. And I want to be very clear. Informed consent is a 4-question multiple choice exam. And the intervention is you are told what size aspirin to take. That's it. So we end up with a 4% accrual rate. Now, I don't want to bluster anybody, but 4% is what we professionals call not that great. But it turns out, this was just published, and I'm glad because I was a reviewer on this paper, so now I can talk about it, even though I don't know if this happens to other people. You get really excited about a paper and then it doesn't come out for 6 months, but you're like, I want to tell people. So this is Vanderbilt, I want to say. They had almost the exact same numbers as us. You can see that for people who were manually approached by a live person in the clinic, their approval rate was almost 17%. But so you're going to think, okay, well, digital innovation failed. We only had 4% of people who did it. If I had just been able to put somebody in the clinic, I would have gotten 17% of those people. However, 4.3% of, in their case, almost 12,000 is a lot better than 16.8% of 339 people. That's the number of people that a single human could approach. So be prepared. You'll always improve upon its success. If you don't have an idea of what you may be accomplishing, you can lose sight of the end goal, which is that they got 87% of their accrued patients from this very, very inefficient online digital process. Also, you can do a lot of innovation with today's resources. The idea of this was to pilot a purely digital trial, nationwide, multi-site, using what was available today, and set a benchmark. We don't know if it's good, we don't know if it's bad. I start telling people that if you run a query and you only get 2% of the people you thought you did, maybe that's just the way it works. 2 to 4% appears to be this data quality breakpoint where you have enough to do something. Other people who are trying to do the same thing. This is the slide that got added because we pushed it back because the press release finally came out. So for the last 9 months, we've been designing the, what do we call it, digitizing the patient journey or the clinical trial of the future with Pfizer. Pfizer's tired of having 200 sites and a rigorous ECRF on a portal they built in 1990 somewhere that everybody has to hand transcribe everything back into. At this point, you're triple entry because you have your CTMS, you have the EHR where things were originally recorded, and then you have Pfizer's online portal. What they would like to do is pull everything for their ECRF straight out of Epic. And what we've rapidly realized is, of course, we're still using the standard infrastructure. Epic is one of the biggest members of FHIR and has ridden that as far as they can, and there's still gaps between what the HL7 consortium has imagined and what is actually useful to a clinical trial. We'll get to that later. What's the logical endpoint of this approach? We have a thing called the O-Bar. It's essentially a digital pharmacy. We have 7 locations and a food truck they just repainted that can go to the other hospitals. You are prescribed a digital device bundle. They're literally across from the inpatient clinical pharmacy in the big atrium and primary care building. You go and you give them your prescription, they give it to you, they set up your account on your smartphone, they make sure everything's syncing, they show you how to charge it, they tell you how it works, they make sure you've consented to your FHIR portal digital transfer, they've downloaded your record. They're a footnote in any of the process and any of the projects I talk about, but none of them work without having a physical space that someone can go and play with their toys and have someone set it up. It's literally the Apple Store model. I'll also say that O-Bar front desk people comprise, I want to say, 75% of the employees of our innovation center. Innovation doesn't take a lot of people. Successful rollout in innovation takes a lot of people. All right, moving on. Digital motion tracking. This is a fun one because it's a private assisted living facility. They have an in-stage dementia ward. Somebody says, there's got to be a way that if I wrote you a blank check, you could make their lives better. So they wrote a blank check, which is great because you don't have to justify feasibility on anything. So in addition to a whole bunch of things that are proven to work, you play people's favorite music to connect them, they feel more engaged, you make sure they have time to be outside, all of that, we put a Fitbit HR on everybody. And people love this. You're like, great. We know things about end-stage dementia, that sleep's disrupted. You don't know how that correlates with sedentary minutes. Are the people who walk more in a late-stage Alzheimer wandering, or is that cardiovascular benefit protecting them? There's so many interesting questions. The data looks like this. I don't know what to do with that. And this is point values per day. This is what they will automatically give you. This is what you can input into Epic via FHIR as point estimates per day. You start stacking it up. I really don't know what to do. One person, dark blue, really liked to walk, right? How do you analyze this? What question do you ask of this? You can get it, but we don't know what it means. And you say, well, it's fine. We'll just move it into Epic, and then we know what it means. But with Epic, you only get point estimates per day. So, and then on top of that, in clinical trials, concomitant medications are not checked. They exist, but you can't record them as a concomitant medication check, which is required by the clinical trial. Likewise, adverse events. This year, they're rolling out an adverse event framework. We're still doing with SmartForm temporarily. It's unclear if the adverse event framework will successfully allow pharmaceutical companies to say, this is the subset of things I actually want. It's fine if it's MedDRA concepts, but there's 1,600 of them. And we don't know what to do with that much data. We already don't know what to do with day estimates. And then you go to Fitbit, and you can start downloading these things at 5-second intervals. And then you go in the forums, and you realize nobody knows what confidence means. Every 5 seconds is assigned a confidence. And I think it's probably the percent of continuous time that the monitor was touching the skin, or that this derivation of 74 beats per minute is how many things did I detect. And so if I detect 4 out of 5 seconds, and then it looks like their heart rate jumped to 40, maybe I just missed a beat, and it's actually 80. But I'm not that confident. But I'm making it up. I don't know. Likewise, it comes featureized, but here, this is sleep. The featureized data set is at differential timescales. So whereas pulse is exactly 5 seconds, and then they kind of guess it here, this person was lightly asleep for 6 minutes, and then had REM for 7.5 minutes, and then was lightly asleep again for exactly 2 minutes. I'm supposed to believe that it was exactly 120 seconds, that all of sleep happens to land at precisely round numbers. So there's something lying in the granularity about the data, and is it featureized? Are you going to build a tiny plateau? Because when I get my sleep tracker for my Fitbit, it gives me some nice waves of things. So obviously Fitbit has post-raw data featureized their own data set and doesn't know how to communicate that. And this, the high-density data, was only available a couple of months ago. But here's what's super, super, super interesting. The patients and the families like it because they feel like someone is keeping an eye on their loved one. We don't know what that means. We're keeping an eye on them. But engagement may be the key outcome. The patients are engaged in the process because they feel like we're trying something new. It's easy to roll out. It's not easy to roll out. So the way it works is the clinical trial coordinator walks in with an iPad, and then she has to log out of the account and log into patient one's account and sync with that device, and log out of that account and log into patient two's account and sync with that device. And so there's an API where we could download all the data from Fitbit for each of our enrolled patients, but you can't sync with multiple devices and maintain separate identities. So her workflow is literally walk from room to room. And we talked about, would it be more cost effective to just Velcro an iPad underneath the bed and just make sure it was charging? It could be. So food for thought. Cutting edge innovation means it's not supported. For all those applications, be prepared for a lot of elbow grease. It's going to get fixed later, but you're going to make something flashy, but it's because you were in there with your tinker's hammer doing it manually. And not support is not just technical. We need to be prepared for new kinds of data, new kinds of analysis. All of that Fitbit data was downloaded and lives on a laptop. There's no other platform for storing and analyzing it. And then I have to go through with a Python script and strip it out and rebuild those dictionaries as time series if we ever want to do analysis. There's just no pre-existing tools to do any of it, although the Fitbit forums do have people who also write Python scripts. And we have to conceive of trial endpoints which are designed around continuous data. I think right now a lot of people look at device-generated data as what I call digital paper. It's filling out your point estimate per day that you would have put on a clipboard by asking somebody. But you have no conception of what to do with actual 5-second continuous data, when you can trust it, what it means, how to featureize it for later analysis. People like to say, oh, we'll just do deep learning on it. All of machine learning works better when there's a human expert intervening and featureizing the data. And then you learn off the featureized data that already has some level of human expert abstraction. But here's my food for thought for this one. You remember this slide where we stacked up all the moments sedentary? I literally go to Google and I said, what happened on September 9th, 2018? It was a new moon, and they all start declining on the full moon. And they're end-stage dementia patients, and you could make me believe that they're connected to a lunar cycle or some, I don't know. We don't know what this means, but if you Google 9/9/2018, you get it was the new, and it was that fall harvest supermoon. It wasn't just any full moon. I don't know what that means. It's fascinating. Products of information. So what it means is non-trivial under the best of circumstances. Does it do anything? Does it do something good? Was it worth anything? I mean, I can obviously wow a room with that slide. We don't have no idea what it means. So what do you know? How do you know what your innovation has accomplished? All right, so this one, the innovation is conceptually simple. As anyone who has become a new parent in the last 8 or so years knows, they strap this like magic girdle on you, and it measures fetal heart rate, measures maternal movement, measures fetal stress. The innovation here is we now mirror all of that to what we call the telestoric bunker. It looks like a stock trading room. I mean, it's just walled with screens, and it's been a staged rollout. But as of today, every single woman who is in labor and delivery is mirrored to a 2 FTE full-time 24-hour-a-day monitored backup room. The intervention is if they notice something funky on the telemetry, they drop an annotation in, and you can't see, but there's a teeny little white box. It says, hey, there's something funky. The on-site nurse has 2 minutes to reply with an annotation, or they pick up the phone. And then they call to the nurse, and frequently it's because there was something funky and the nurse is dealing with it, and that's why they don't have time to type. So then what's recorded is whether or not the nurse was aware that there was something funky. And frequently, funky is just the woman rolled over, or she disconnected telemetry and went to the bathroom and couldn't get it reattached. It doesn't mean that there's an emergency, but it means that there's something that people need to keep an eye on. So what's the innovation? Is it, if I'm doing this evaluation and they come and they say, does this work? And you're like, well, what does work mean? And the answer is, does it decrease unanticipated NICU admissions? But what's the innovation? Are we tracking everybody who's ever been mirrored on a screen, or do we track the number of times the phone was picked up and the on-site nurse was not aware, which you could argue is the only time that remote monitoring impacted care? Well, the actual noted impact was a decrease in the number of calls. It was a phased rollout. This is replicated across multiple sites. But in the 3 months after they start telestoric monitoring, the number of calls they have to make drops. So is the intervention that people pay more attention if they know that someone's watching them? Is this like literally a activated Hawthorne effect? That was my Adam Wilcox fun fact from many years ago. If I recall correctly, it was a vacuum factory. But what is the innovation? What is the intervention? What do we measure? And I will say we're waiting on an extremely slow view to populate so that we can figure out which babies. All right, even simpler, fall risk monitoring. Just put a camera in the room. It's the same. They have a bunker. They have a fall risk bunker. Here's the problem. A device manufacturer comes back and says, these numbers are great. That's fantastic. We really want to get involved in your program. We don't know where these numbers came from. This was a consumer publication. They talked to somebody. So we go back and we try to replicate this, and it's very easy to replicate the decrease in the fall rate. They don't keep track of which rooms actually have cameras because they're stored in a closet, and when you go, it's like a third of the rooms. So having cameras available to be rolled out appears to decrease fall risk if you just put them in a third of the rooms. And somebody talked to somebody, and it's this quality care coordinator. She's quoted in here. She's very nice. But she just starts talking to someone, and next thing you know, you're in a headline. All right, here's the other part of evaluation. We have a 3D printing and augmented reality lab. They are the ultimate example of engagement through personalization. They take in extremely complex data. They will start with your MRI. They will print your spine. They will hand it to you and said, this is why you can't stand up straight. And you've never seen a more engaged patient when they break out into tears and finally understand why it hurts to move. And then they can build the tools they're going to insert to fit your spine and sit there and walk you through how they're going to attach to the curve in your spine. And they're going to straighten these pins and your whole spine is going to straighten out. Likewise, this is not a decapitated zombie on the bottom right. That is our training sim lab, and they're using VR, or augmented reality. And what's fascinating here is, so you can see and pour, they visualize the aneurysm of the tumor, they visualize all the vasculature, and then they put the PET scan overlay on top of that. And they give it to a surgeon to plan his approach. And so now that surgeon can not only design an approach that misses all your major blood vessels, but also make sure you can remember your childhood when you wake up. And they come to us and they say, well, that's great. How do we evaluate? We found this score for scoring extremely complex surgeries. Do you think we could digitally calculate all this? And the answer is, well, one, no, because it's entirely subjective. And two, you still don't have a control group because your intervention made the impossible possible. Your evaluation is take a stack of charts and scans to a conference, have your colleagues sit down, look at the chart, say, would you operate on this person? Then put them on the VR helmet for 10 minutes and say, would you operate on this person? If they changed your mind, that's the impact. You're never going to get outcome study on what used to be impossible. All right, it's sometimes easier to put together amazing things than to know what do they do. Increased monitoring, increased compliance, increased access, increased awareness, increased patient engagement, maybe goals unto themselves. And the great part is you can promise all those for almost anything you do, because if that patient feels like they're paying attention to you, you are paying attention to them, they're going to be more engaged, you're going to get all of these things. Deciding what those things do is harder to measure, harder to evaluate. It may be that it does nothing constructive. So here's my permission. What do you do if you want to do a systemic evaluation? Plan it before you start. Make sure you're measuring who got what you qualify as an intervention. That's our #1 challenge. Someone has a great idea. Great ideas are easy. They run a pilot program. That's fantastic. Then they want to roll it out system-wide. And we're like, okay, give us the list of the people you did it on. Well, we did it on everybody. But no, you didn't. You didn't. You opened an order set on everybody. You did something on everybody. We have no record of who actually got what. And so now you've polluted all of your data back to a baseline. And even worse is when you do something really neat and people start doing, by example, the progressive mobility plan without anyone ordering the order set, because a physician doesn't have to order it. It's a simple set of goals and patient interactions that every day try to move people to regain lost functionality. We don't have a record of who didn't have it ordered and got it either. And what do you do? So be honest about what you want. As I said, increased access, increased engagement, these are all laudable goals unto themselves. So is publicity. Publicity is a pursuable outcome, and I would argue it's the #1 outcome the Innovation Ochsner Center is trying to build for very good reasons. If you do this, you change healthcare. Adam always said, your study is not done until you've published, because it's not what you know, it's what you made everybody know. And publicity is the academic publication of innovation. Maybe, I don't know. But that's not what we're here for. So what would I say works when it works right? We have a digital medicine program. There's 3 flagship programs, Staying Healthy in the Digital Age. How it works, you in primary care are diagnosed with some condition. You're prescribed a device bundle. You go to the OBAR, they set it all up, they build your account, they consent you to fire transfer of data. You measure yourself at home. Your point value estimates per day are transmitted. Here I'll say one of the things we do is we have this philosophy that no doctor ever sees a time series. And it's not because doctors are dumb. It's because once you subtract all of the other things they have to do, what's left of their brain is not much smarter than your average patient. And so you have to make it just as simple to understand. Now, they always have the capacity to drill down, but there's a whole team of people who design abstracted dashboards for patient panels and then individual patients who have crossed some threshold so that no physician is ever actually looking at time series, but all the time series are collected. Then the patient navigator contacts the patient when appropriate. So the flagship is digital hypertension. You get, I pulled this one, they actually don't give you this one anymore, they give you a much less futuristic looking thing. But this you just strap on your arm once a day, it measures your blood pressure, you weigh yourself every day, and then if you deviate outside of a couple of pounds or your blood pressure shoots up or anything, you get a phone call. It flags an alert and you get a phone call saying, how are you feeling? Did you have a crawfish boil yesterday? Did you eat a lot of salt? Maybe we need to schedule you to come in. And because it's a big enough number of people, they can maintain a same day or next day scheduling block because it's predictable. This was actually published for my human-computer interaction only person named Sean over there. This is something they actually test drove for patient understanding. So they did actually test drive it. The average number of measurements is 4.2 blood pressure measurements a week are imported to the chart, and they have 71% made compliant blood pressure in 90 days versus 31% of the control group. And the control group was given all the same education, they just weren't measuring themselves and they weren't getting a monthly summary of their performance. And I'll mention that lead author on that study is Dr. Richard Milani. He is the Innovation Center's his brainchild. So he started as he's still a practicing clinician, but started as someone who ran a pilot project and then said, how do we generalize it? Let's build a center. Diabetes, it's the exact same thing, it's just glucose monitoring. And what I really like is the connected mom because the effect is opposite. If you are on a normal growth curve, do not have abnormal blood pressure, and your urine protein strips are coming back, and with that, you dip it in, it changes color, you take a picture with your phone. And that's what goes in is the digital image of the color, they start dropping your routine follow-up visits. If they know how much you weigh and you don't have hypertension and you're under the age of 35 and you're not gaining an explosive amount of weight in your pregnancy, you don't actually need to come in. They can drop 1 out of 3. And it's amazing. Nobody actually wants to go in. All right, why does it work? In my opinion, it's innovative without being too innovative. These 3 programs operate within known healthcare frameworks where the primary intervention is increased frequency of measurements. They're very clever about what they measure, but they're treating these devices like digital paper. They are embracing the fact that they can only make decisions off single-point estimates per day. And because they're based on being 1 step forward from a person coming in and having their blood pressure measured, they already know what to do with the answer. The evaluation of the meeting of its goal is clear. It's 90-day compliance with blood pressure goals. It's you have a normal growth curve on your pregnancy, you don't need to come in. It's your diabetes is remaining controlled. You don't need to come in for routine maintenance. I can see your blood glucose levels. Why does it work? Well, you saw those people in the digital healthcare, where there's no intervention beyond measuring themselves more often and getting a PDF of their performance. So what's the intervention? It's better outcomes through better compliance. It's better compliance through participation. It's participation through personalization. But it's just measuring yourself more often, which should not really change your health. And it's getting a piece of paper that puts your numbers in some green colors or some red colors or something. But why it works, I don't know. Maybe at a certain point, an intervention is just something that has an effect. So in reality, the intervention for an entire digital program is that piece of paper that they get mailed if they don't like email. And it doubles or almost triples compliance and time to target therapy. All right, digital patient engagement, building an innovation center, practical questions. All right, so our innovation center launches in March 2015. It's fantastic. Headlines everywhere. The secret is their first publication comes out more than a year before, which means they submitted it 6 months before that, which means they did the work 2 years before the center starts. Innovation doesn't require a center, but a center requires innovation. And I think the way to look at it is you don't start a center and you start to innovate. You look for where innovation is happening, and you draw the center around that. And it achieves 2 important goals. One is it makes it look like you've already done something. But 2 is that it establishes what I call fierce independence of innovation. You stand as a center because you're the only people with the foresight to innovate. And you find the people who already had the foresight to innovate, and you build the center backwards. That's exactly what we did. The splash is March 2015. Even on the website, the timeline starts in more than a year ahead. And then that was not the only prior milestone to the launch. But even in the same year, in the 9 months following, there's more self-reported milestones on their website than there was prior. So building that center, getting that logo, putting yourself on a billboard, it's still a launching off point. It just doesn't start with the idea and a logo. It starts with what's already happening. The other thing you need is support. So these are arguably the only 2 people who are driving innovation within our center. They employ many more people, but you're looking at the CEO and the Chief Technical Officer, Technology Officer. Everybody else is kind of trained monkey level of Epic integration. I don't know if you... They want you to hire people who just do one thing, and it makes for very clear management, very clear security, but it doesn't allow for a lot of creativity. And so finding people who follow the exact right path through many years of the Epic analyst pathway and then arrive at a place that they have a global vision is incredibly hard to find. And then they have to have passwords and still work to build stuff. But it works because Richard Milani is the Clinical Transformation Officer for the Ochsner Health System. He doesn't actually have an Innovation Ochsner title, but it is his brainchild. He's the person they're all talking to and going to for approval. And it works because they have the unquestioning support of the CEO of the entire system. And so when they say, we want half a floor of your new hospital expansion, he says yes. And when they say, we've got this crazy idea, can we use copper doorknobs in our new hospital wing? And he says, why? And he says, well, everyone's known since medieval times that copper has antiseptic properties, and we know it works, and so now everybody's getting a hand wash every time they open a door. Can we try that? He says, okay. And it works because of the unquestioning support. Now, it is kind of a question of pilot-itis, So they have a hard time building things that leave that half a floor, partly because as soon as it's easy to roll out the pilot, but they don't have the capacity to manage system-wide implementation. And so that's why they've gotten much better at partnering with outside larger branches, because we, let's say research administration, can do and evaluate system-wide implementation. So we're jointly doing the Pfizer strategic partnership, all kinds of stuff. Those, I would say, are the two main considerations. Start with what's already going on, make that your center, and two, make sure you have the unquestioning support of your senior leadership, because these things cost money, they will make a splash, but you have to know and be honest about what you want, what outcomes you're chasing, what you know you can definitely prove that you're going to sell. And then afterward, you run the evaluation on what the innovation actually was it cost effective on your capitated population, and then you roll it out for everybody. All right, conclusions. This is paraphrased all of my food for thought slides, so I'll leave that up there because I think the next one just says end. Fantastic. But yeah. Don't forget that talking to people will always be the best engagement. It's easy to come up with neat ideas, and they will do something good, but you may not know what it is. And just be honest about what you really, really want.
I appreciate, on behalf of the room, getting some vision into the opportunities that we have. And some of the things I took away, actually from both of the discussions, were the opportunity to do some things. I liked Albert's 3 months. At first it seems daunting, but for those of us in IT, as we start thinking about Agile and Scrum work, that's exactly how we start to innovate, to get something out there to continue to innovate on. So I think it's great not to get sucked into this will take 10 years to do and then have nothing out there as well. And how it maybe increases our brand presence in the communities. I know Dan had said that they corner 90% of the market in Louisiana, so their brand is the brand of Louisiana, but I know that in Albert's market, there's many brands, and so the opportunity to get that brand where people are there as well. So I think it's great to look at those things. One of the things we look at in healthcare is kind of that balance between traditional come-to-me medicine, digital innovation that allows for patient engagement differently, and oftentimes the physician sitting in the middle of that. And knowing that they have to do both of those, and you find the charts that Albert has where people are spending 2 hours on documentation and great ideas on that as well. But I just would open up to ask you guys, how are your physicians that practicing in the clinic all the time participating in these things to make sure that they're seeing the benefits they want to see from patient engagement as well as they continue to care for their patients?
I guess I'm one of those, so I should answer the question. We actively try to recruit physicians to participate in the process, because if we don't have their engagement, the initiative fails, almost certainly. One of the reasons why I've been progressing towards this agile model of every 3 months is it provides evidence of change, positive change, that people feel empowered. And one of the things that I think really contributes to burnout, in addition to the high volume of messages and so forth, is frankly a lack of control. I believe there's a change in the social covenant between doctors and society in some sense. We used to be quite autonomous. We used to have positions of power and so forth. And when you don't control your environment, you feel a sense of loss of autonomy. So one of the things we were trying to do with this agile pace is to say, change can really happen, change that you can palpably feel and touch and see improvements.
Do you have any?
I'll also add that much like the patients, I think our physicians report they'd like to know that it's possible and that somebody helped them do it. We track how many times those drill down dashboards are drilled into, and it's once per day for most of primary care. And so, but the major point of engagement is it's just like with the patients. They want to know that somebody cares, that their patient cares, and that the system cares, and they've provided a capability and then hopefully put some thought into its usability. And so that's part of the implementation of making sure you're putting in something that people like and something that works. But after you've rolled it out across the entire system, what people like is knowing that they're being engaged with. The physicians like to know that the system is engaging with them as well as the patients.
So I know we only have a minute, so I'm going to start out there. Bill, you have questions?
I'll try and ask quick.
Yeah, there you go.
So I was intrigued that you mentioned the OBAR twice in your conversations, because that's one of the things that your health system is obviously well known for, among many. The thing that's always interested me about the OBAR is it represents kind of a confluence of that patient's engagement with several different digital streams, several different digital health applications, programs, whatever. And so, broadly speaking, we have a world where there are lots of different apps for lots of different conditions. I think it's interesting that you guys have established that patient support as one of those touch points. And I'm interested to know if you both think that there are other touch points. Maybe it's getting the sort of destination one approach of getting everybody to use a common portal for everything. Maybe it's the integrating provider visualizations. I'm not sure what it would be, but are there other places that you've thought that all of those streams ought to converge?
Patient navigation and scheduling is the obvious answer. And so if you have somebody who doesn't know what they don't know and they come in, who does that person call? Who is the first person that person talks to? And they have to have a at least small degree of clinical knowledge in order to ascertain whether you can steer someone toward high-functioning primary care or if they need specialty care. And then beyond that, that can all be supported with, given this chief complaint, what are the likely tests that will be done? Can we say, well, if they have a primary care appointment now, we need a 50% coin flip that they need an MRI that afternoon. And so you're starting to put together numbers about patient flow through the system and common patterns. And so it works much, much better in something like knee replacement, where you can build the entire care pathway. But there are opportunities to centralize multiple appointments within a span of time by saying, there's a good chance this person will need a referral. And if I get 10 of these people a week, and when we have 3.6 million patients, or 775 unique patients a year, 775,000 unique patients a year. And then this is something I'm going to give full credit to my wife for. So she's a practicing emergency medicine physician.
Good man.
Yeah, and
good man.
She always asks me to pull numbers that she can't get out of Epic's reporting system because I just go query the database directly. 28% of our entire healthcare system only has 2 or fewer encounters a year. And if you have 2 or few encounters a year, 85% of them, it's a guarantee that one of them was emergency services, either urgent care or emergency medicine or something. If you are between the ages of 25 and 45, you're only going to the doctor in an emergency. And you're not seeing a doctor, you're going to an emergency department or an urgent care. And so her idea is, what can we funnel into that? If we can learn enough about the patients who interact with our healthcare system to say, guess what? This is my only chance as a healthcare system to touch you. What else do I wish I could do today? And so she's trying to build a business case for stashing a primary care nurse practitioner in the emergency department to say, all right, everybody line up for your flu shots. You're here. This is the only time you're coming.
So to extend the OBAR concept, one of the things we've actually done is we realized if people can't log in, for example, they really can't take advantage of all the things we talk about. So we've actually established in Utah a call center that provides services 12 hours a day, 5 days a week, 23 FTEs, actually. So we made a strong investment in supporting patients because we figure that's the initial point of contact. That's our front door. So we got to make sure they can get in the front door. So it's both patient support services for our portal and actually a large party of people do centralized call center work as well. So,
and just to add on to that, one of the points I remember adding late to my talk that I missed doing is always keep an eye on the people your innovation have excluded. So when we ran that evaluation of the digital hypertension, 60% of people fall out because they didn't have a smartphone. And it's not because 60% of people don't have a smartphone, it's 60% of people over the age of 65 do not have a smartphone.
Yep.
That's different in Louisiana than the rest of the country then.
Yeah.
Yeah. So.
Well, we're very different states.
Yeah, there you go. I have a
Sure. Hi, Brian Krayback in Rehab Medicine. So I want to go back to the point of clinician engagement and perhaps change it to stakeholder engagement. And how do you define ROI is by the stakeholder, right? So as a clinician, right? I embrace the e-care portal. I love it. I actually get my patients and say, hey, this could be very beneficial and follow up with that. But I also appreciate that I do that in between patients. If I have a minute, I throw that in there to try and address those questions. And as someone who's based on RVUs, I know that that's worth 0 RVUs, but improves patient satisfaction and stuff. So how do you gauge having the time to answer such things as these e-care messages, knowing that the system is wanting me to see patients, and we know we don't want to expand my hours because I'm going to be burnt out. So how do you balance that friction between kind of administration ROIs, the clinicians' ROIs, the engagement of the whole entire system, so that it's becoming more efficient and we're not just shifting, as the one metric showed, right? All of the metrics are shifting towards physicians and residents, and everyone's spending more time on documenting progress notes and stuff. So you can get the clinician engagement. How do you balance that friction between those different stakeholders?
Well, if I knew the answer, be a very, no, I mean, I practice. I still practice too. So I mean, and my in-basket's awaiting me. One of the reasons why I published the work we did and we talk about this publicly is I think we're ahead of the national discussion. You know, you think about meaningful use and other things, we're going to start to see volumes of messages just ever increasing, and we're just a little further along in that maturity curve. So I hope that we can form consortiums, partnerships to figure this out. I mean, truly. I mean, are some of the solutions AI? I presented an example, that AI little tool. We hope that what that'll do is allow patients to self-navigate instead of sending an e-care message to you to ask the question. So we're trying a number of different interventions in that regard. We've developed standard work for our nursing assistant, medical assistants, to be able to try to track some of this work. But it's a real problem, and we're trying to figure it all out. I mean, not being transparent.
The only thing I'd add is that you're always going to have adopters who adopted because they love the idea, and you're going to have people who won't touch it. And so part of that is just making capability, demonstrating it works, and then leaving it up to that clinician to learn from their peers. And someone will say, hey, this is really great. Look, this person didn't come back, or did come back, or I caught something, and doing it that way. But it's, as you said, it's engaging not in a logical path of RVUs. Although I would argue we can tell how many inbox messages you answered. There's no reason it can't be reported on.
I will say in our organization, some of our medical groups, in fact, incentivize timely response. So they recognize that work, and that's a useful feature. I hope that legislative advocacy ultimately results in some recognition of this work, because this was real work. It's digital work, but it's real work that physicians are doing. Yeah.
Deb? Yeah.
Hi, I'm Deborah Gusson. Dr. Chan, we've not met, right?
I don't.
Okay, but this is a true thing. I mean, it's actually fascinating to hear your conversation. My sister.
Is this like a magic trick or something?
Well, it could be. I don't know. You're really nervous right now, which I'll enjoy for a minute.
No, I'm not.
My sister and I moved my mother to Roseville, which is a suburb of Sacramento, last year because her health was failing terribly. She had been in and out of the hospital. She was really in a terrible state. And she is now one of your 1.7 million enrolled patients who's actively using. But it's been transformational for her. I mean, she is healthier and stronger and really feels, her mental state is way better. And she loves the connectivity. So, part of it is, I think we do, she's 79 years old. I think we tend to underestimate our older patients, and she can be a handful, by the way. But this has worked.
I look forward to meeting her.
You may have. It's worked miracles for her. But I think it's to the point of what is the intervention. She feels connected. And just a couple of weeks ago, she had a major crisis, but immediately knew who to call. They responded right away. They did the thing they needed to do. Last year, she would have been back in the hospital in ICU. I'm convinced of it. And this time, she was not. She got all of her care. She's getting better. She's stable again. It's making a real difference. So, I want to say thank you. But also it gives me great hope that the things that we're doing back to the patient perspective really do matter. I think from our patient's view, when it works, when all the dots connect, it really is making a big difference. And I'm really optimistic that what we're beginning to build is going to have those same results as well. So thank you.
Thank you. Truly, thank you for sharing. That's what keeps you going through those long, hard nights and so forth, right? These kind of stories. Thank you.
Dan? Yeah.
Dr. Chan, this is a question for you, Van Chowdhury, Population Health. As our system, and Deb alluded to this, as we start to make wellness a priority for ourselves, for our patients, as we start to move and acknowledge also sickness, but also wellness and keeping people proactively healthy, what do you think is the right balance? You gave some great examples in your presentation of automation, alerts, but then you also talked about the expense, but also the flip side of talking to a person or engaging with a real life person. What guidance could you give us as we sort of navigate that terrain of reaching out to our patients to keep them up to date on health maintenance and bringing them in as needed for prevention of disease and good health? How do we balance how much to automate, alert, or call people, outreach to people, and any advice around that?
So second Rich thing I'm going to get Rich on if I can figure that out. But no, in all seriousness, one of the things we do is we have a patient and family advisory committee. It's actually very robust. We're a distributed system, so we get different geographic inputs. I would really encourage you to involve patients in that process because you may be designing something that really is not the right thing. You got to go out and ask. I mean, I know it seems like a duh, but back to the duh statement. But that's one thing I would definitely do. The other thing I do, frankly, is I steal. So I look at other... hi, camera. Look, healthcare is generally behind, right? You look at other industries, the experiences have been already tested. So why don't you use that as inspiration? And you can tell what things that are accepted for automation that this text reminder thing happened because, frankly, as I was giving this talk to the CEO council, our CEO got a text from our hairdresser. I'm not even kidding. I could have paid this hairdresser, but I didn't. I promise. It was perfect timing, and it illustrated the point. So if you could look for other inspiration, other exemplars of things that already work, steal.
We're going to have to close this up for this time, but certainly our speakers are still here. But I'll just. Do you have 30 seconds each of just kind of a closing of either good luck or some note you might say? Again, I like your points that technology enables, but it's not the technology that makes that change as we go through it. So either one have any parting comments for us?
I'll always say that that's nice you touched upon that. When I look at the amount of time I spend with people in the Ochsner health system, I realize just how much of my job is saying, go try. Go do it. There's nothing stopping you from doing this. That sounds great, and we can help you. And part of it's because there's a 90% drop-off at every step of implementation. But what stops more people is just not realizing what resources they have available in a modern functional healthcare system, how to access them, how to use them, and who they can talk to. And then someone to just give them a big thumbs up and say, go do it. So go do it.
Absolutely, totally, Dan. I guess my parting advice would be find a robust change model. So actually, my team after a while figured out, hey, this guy's doing it by a script. So I do. I use Cotter, okay, but whatever. I mean, I have great patient stories. I develop timelines where I'll get quick wins. That bolsters the incentive to keep going. Things like that, I think it's really important, truly important. And then that's how you can really recruit a coalition of the willing. Because there is no way any individual leader can make this happen without the coalition. And the initiatives I talked about, even the text reminder thing, we're talking about hundreds of people that had to change their behavior across the system. So my piece of advice.
Well, can you thank Albert and Dan with me?